Good morning, everyone. I hope everybody can hear me. Welcome to the second in a series of public webinars delivered by the SingHealth UK US Head and Neck Center. Today's topic will be Nasopharyngeal Carcinoma, or the nose cancer, also known as the hidden threat. We are lucky to have a few specialists with us today who will be speaking to us about three separate topics. First one will be signs and symptoms of nasopharyngeal cancer, followed by treatment for nasopharyngeal cancer, and finally, surgery for nasopharyngeal cancer. To begin with, we'll have Dr. Constance Teo, the Head and Senior Consultant from the SingHealth UK US Head and Neck Center, and the Senior Consultant in Otorhinolaryngology, give an opening address. Dr. Constance, please go ahead. Dr. Constance, I think you are muted, please.
Apologies for that. Good morning, everyone. Yeah, so first and foremost, I'd like to welcome all of you to this webinar on behalf of the team from the SingHealth NUS Head and Neck Center. Why are we talking about nasopharyngeal carcinoma? Because it is actually the commonest head and neck cancer in Singapore, and the symptoms are often very insidious. And we hope that in today's webinar, we can, educate some of you so that we can actually pick all this up earlier and it translates to better outcome for our patients. Very often, all the symptoms are very similar to what you have in a cough and cold, but not all cough and cold are cancer either. So we don't want all of you to panic, but we hope that, if there's anything you'd like to clarify with us today, we'll be happy to answer in the Q&A. So we have a very nice team today from the experts from Changi General Hospital, from National Cancer Center, and from Singapore General Hospital. So I won't delay anymore, and I'll pass the session now over to the team. Thank you very much. Yeah.
Thank you, Dr. Teo. So the first speaker today will be Dr. Lena Tan, who's a consultant at Changi General Hospital, Department of Otorhinolaryngology. He'll be talking to us about signs and symptoms of nasopharyngeal carcinoma. If you all have any questions, please feel free to type them up into the Q&A feature of Zoom. Do not use the chat function because it will be difficult for us to track them there. Use the Q&A session again, and we'll attempt to address as many of the questions as we can at the end of today's presentations. Dr. Leonard, please go ahead.
Okay, thank you, Simon. Let me just share my screen. Sorry, can I trouble the organizers to stop sharing the screen first? Okay, so I hope everyone can see my screen. My name is Leonard, and today I'll be talking about the signs and symptoms of nasopharyngeal carcinoma. So this is the breakdown or the scope of my talk. I'll be giving everyone a very brief introduction, and then I will go on to the meat of the presentation, which is the signs and symptoms of nasopharyngeal carcinoma. And then I will talk briefly about the diagnosis and management, as most of this will be covered by my two other colleagues in the subsequent two talks. And then just two very short case examples to illustrate some of the points that I've mentioned in my presentation. So I think the nasopharynx is an area that has garnered a lot of attention recently, and that is because we have been doing a lot of PCR swabs because of COVID. And what exactly is a nasopharynx? I think we need to cover this before we talk about nasopharyngeal carcinoma. And the nasopharynx is essentially an area that's actually within this circle on the pictorial diagram on the right. It's actually behind the nasal cavity, and it's sitting above the soft palate as well. And this actually directly communicates with the throat, which is also labeled in this diagram known as the oral pharynx. It has also connections to the ear, and this is actually connected to the ear via a tube that's actually located within the region of the nasopharynx called the Eustachian tube. I will talk a little bit more about this in the subsequent slides. So what is nasopharyngeal carcinoma? Essentially, is defined as a cancer that develops from the lining of the nasopharynx. It is also known, locally as nose cancer. And of course, in the nasopharynx, there are many different cell types, and different cell types can actually give rise to different cancers. And the most common cell type that we see in Singapore is actually the squamous cell carcinoma. So nasopharyngeal carcinomas actually affect men more than women. And unfortunately, based on the Singapore Cancer Registry Annual Report 2019 that was published earlier this year, it is the 8th most common cause of cancer deaths amongst males. And of course, it's also the top 10 most common cancers by incidence for males between 30 to 59 years old. And of course, there's a tendency to run in the family. Now, we also need to know a little bit about the risk factors. Of course, like what I mentioned previously, it occurs more commonly in males. It also is a higher incidence in people of Southern Chinese descent, and of course, a family history of nasopharyngeal cancers, in which there's 2 or more first-degree relatives with NPC, and first-degree relatives can be defined like such as your parents as well as your siblings. And of course, a previous Epstein-Barr virus infection, which most of the population in Singapore would have it already. And of course, a diet high in salt and preserved foods. So moving on to the signs and symptoms, I think basically nasopharyngeal carcinoma can be very insidious, like what was introduced to us is actually a hidden disease, because at the early stages, it can be completely asymptomatic. And, and of course, the signs and symptoms actually may develop as the cancer progresses. And I think to illustrate this is that on the bottom right clinical photograph of the nasopharynx, you can see that there's a mass growing in the nasopharyngeal area. And such a small tumor may actually present with no symptoms at all. So this patient that was seen in the clinic actually presented with very non-specific throat symptoms, and his scope performed for him incidentally picked up this mass at the back of the nose. And I think to better understand why some of the symptoms and signs occur, I think it's best to first understand, what are some of the surrounding structures in the back of the nose. So I think let's just focus on the photo or the diagram on the left side first. And this black arrow actually points to where the nasopharynx is. So you can see if there's a tumor that grows out from the nasopharynx, it's actually in very close relation to the first structure that I mentioned at the start of the talk, which is the Eustachian tube. The function of the Eustachian tube actually is to equalize pressure in the ear, and also secondly, to drain out whatever fluid that's produced in the ear. So you can imagine if there's a tumor that's blocking off the Eustachian tube opening, it can cause problems to the ear. Now, secondly, in this diagram, there are photos showing a lot of nerves. These nerves may not be affected by the nasopharyngeal carcinoma, but I just wanted to illustrate the point that there are many nerves and vessels surrounding the nasopharynx, and these nerves and vessels can also be affected. Secondly, and lastly, of course, on this diagram, you can see that it's also very near bone. So the bone in the spine area can also be affected as well. Then we change our attention to the photo onto the diagram on the right. You can see that actually although this is not a cut where the nasopharynx is, but behind the nasal cavity, this photo in the center shows the nasal cavity. Behind it actually sits the nasopharynx, and the nasopharynx is actually very closely related to the eye as well as to the brain. So some of the nasal symptoms that you can get, or what I group as the nasal symptoms, would be number 1, blood stain, phlegm, and saliva. So you can imagine if there's a tumor that sits in the nasopharynx, and because of its connection to the throat, blood can actually drip down the back of the throat, causing patients to present with a blood stain, phlegm, or saliva. And if somehow the blood or the tumor is big enough and it flows out through the nasal cavity, patients can also present with nose bleeding as well as bloody nasal discharge. And of course, you can imagine if the tumor is big enough, it can block off the back of the nose, causing blocked nose that can start off as a single-sided blocked nose and then progressively becoming, it can occlude both sides of the nostril. The next signs will be in the ear. Of course, like I mentioned just now, if the tumor blocks off the Eustachian tube, it can actually cause fluid to accumulate in the ear. This can result in hearing loss. Sometimes with the hearing loss, our patients may also just present with blocked ear sensation if the eardrum or the Eustachian tube, is not totally occluded, but just partially occluded. And also because of this blocking, patients can also hear a ringing sound in the ear that's persistently there. Well, other symptoms, neurological symptoms, like what I mentioned just now, is very close to nerves. So patient can present with facial numbness. Patients can also present with double vision when the eye is directly involved, 1, or 2, if the nerves that control the muscles of the eye is affected. And of course, if it affects the brain, it can cause headaches. Patients can also present with a painless neck lump in the neck, like this gentleman in the photo on the right. Patient actually presented with a neck lump, and this spread of the cancer to the lymph nodes. And of course, patients can also present with symptoms of distant spread if it's a very advanced disease of spread to the lung, liver, and the bone. This can result in pain such as if it's to the spine, it can cause back pain, or it can, to the lung, it can cause shortness of breath or cough. I think when should you seek help? I think basically if you have any persistent symptoms for more than 2 weeks, or any signs and symptoms that worry you, that is also persistently there. And of course, if you have a strong family history of nasopharyngeal carcinoma, and that is defined like what I mentioned previously, if you have 2 or more first-degree relatives. So just very brief about the diagnosis and management, because it'll be, like what I mentioned, covered by my colleagues later. So when you come and see us in the clinic, well, the head and neck surgeons or the ENT surgeons will do a couple of things. Number one, we will do a complete head and neck examination. So basically, we'll examine you, in the head and neck region completely. And of course, second, and this is completed with the examination of the nasopharynx using a scope. And then if we see anything that's abnormal at the back of the nose, we can then, do a simple biopsy in the clinic under local anesthesia. And of course, let's say if there's a neck mass, we can also perform a very small and quick needle biopsy under local anesthesia. The results will usually come back within 1 to 2 weeks, depending on the institution. And then after that, if it's confirmed to be cancer, we definitely move on to staging. And staging is done using scans. So the scans, we will do a scan of the head and neck region, especially in the nasopharynx, as well as the neck. And then after that, we also do staging scans looking at the rest of the body. So let me just show you a video of a simple scope that we do in the clinic. It will start off from the left nostril, and then it will quickly switch to the right nostril. So I wanted to show you what we are seeing in the clinic. So it starts off with the left nostril, and we are moving through the left nasal cavity, going into the nasopharynx. And so this patient has a normal nasopharynx. You can see the Eustachian tube actually opening on the left side of the video, or on your right currently. And then we are flexed over to look at the opposite the Eustachian tube opening. You can see actually the nasopharynx very close. And then we can also flex our scope down to look into the throat. So this patient's throat has undergone some form of surgery. You can see the vocal cords very well. And then we can come back out to have a look at the nasopharynx again. And then we will then examine the rest of the nasal cavity. And this procedure is then subsequently repeated on the opposite side, which is the right nostril. So we are moving through the nasal cavity, and looking at the nasal cavity again. And then we have another view of the nasopharynx at the back and the Eustachian tube openings. Okay, so the management of the disease is based on, very briefly, based on a couple of factors. So number one is the size and the type of the location of the tumor. And of course, the stage of the disease and the patient's general health. And of course, the details of treatment will be covered by my 2 other colleagues later. So I think just wanted to do 2 quick case examples of patients that I've seen in the clinic. The first one is, of course, an atypical case that occurred in a female. Although it occurs mainly in the males in Singapore, but it can also occur in a female. So this is a 38-year-old Chinese female that had no family history of nasopharyngeal carcinoma. She actually presented with very subtle left neck swelling for about 2 months with a left block ear sensation. And she also had some blood-stained saliva. So we look into the ear, you can see actually this is the diagram of the left, a photo of the left here, and you can see there's some yellowish fluid that's actually sitting in the middle part of the ear that's behind the eardrum. And this is suggestive of what we call fluid in the middle ear. And then we did the scope for the patient. You can see at the back of the nose, there's actually a very big tumor that's occupying the entire nasopharynx. And this is in contrast to the scope video that I showed you just now. So a biopsy was done for her, and it came back as positive for nasopharyngeal carcinoma. We sent her for treatment, and I've been seeing her in the clinic for the last 2 years, and she's well. So the next case, just wanted to illustrate a point that patients can actually present with symptoms other than the symptoms that are presented. So it's a 50-year-old Chinese male that I saw recently, no family history of nasopharyngeal carcinoma, had a presenting history of just some runny nose for 6 months associated with a cough with no other symptoms. And of course, when we did a scope for her, for this patient, there was a mass actually at the back of the nose. And I actually did a biopsy for him, and he came back positive for cancer. and he has chosen to return back to his home country in China for further treatment. So with that, I've come to the end of my presentation. Thank you very much for your time.
Talk, very nice introduction to the signs and symptoms of the nose cancer, which we are talking about today. The next segment will be delivered by Associate Professor Chua, Melvin Chua, who will be talking to us about the treatment for nasopharyngeal carcinoma and what is it that the patients need to undergo once the nose cancer has been diagnosed as described by Dr. Tan. Dr. Chua, please go ahead.
Thank you, Simon. Can I just allow me to share screen? Okay. Continue. So thanks for everyone for joining this morning's webinar. And I think it sort of gives me a bit of time to sort of go through some of the treatments that we do for NPC, and which is essentially nasopharyngeal carcinoma for short. And I'll try to dispel some of the myths, and I'll sort of try to do that with a lot of photos. So, I'll take some time to explain what it entails with regards to chemotherapy, radiation, and how do we sort of coordinate the follow-up with these surgeons. These are my disclosures, nothing relevant to my talk. So I thought I'll start with a case. So this is a patient of mine, fairly young chap who came in with, basically blocked nose. As you can see, this is the MRI scan showing that this is the right, this is the left, that can appreciate some asymmetry on the left-hand side. And then it's very close to the bone that's separating the nose and the brain. And this is another section here where you look at the patient face on, and you can appreciate that there's some thickening on the left side. Now, it's easier to appreciate this on the PET scan, which you show here, where essentially everything that's maybe potentially cancerous, ignoring the brain, is bright. So, this segment here you see in the nose would match that to the MRI. And so I'll go through how we stage nose cancers later, very briefly, but essentially, apart from stage, the point I want to highlight here is we look at, when we think about treatment, we think of the risk of the patient, and we adopt several parameters beyond stage to then decide what should be the appropriate treatment for the patient. And we looked at a viral marker, which I'll sort of go through briefly. So this is Ebv Dna, which is a liquid biopsy. That's a clinically available test that can be done for patient. And naturally speaking, the higher the level, the more aggressive or high risk the cancer would be. And then also we look at other things, including the volume of the disease. So here is demarcated as GTVP, but it reflects the volume, and anything more than 45 or 50 cc usually would indicate that there's a big tumor. And so, but the point to the patient is, how do we treat this young gentleman, right, who is essentially just turned 40s and got a long life ahead of him? And just to take a step back and bring us, refresh some of the facts again to the public. I think one of the things that I find people always ask me is, why do I get nose cancer? Why is it so prevalent in Chinese? And the point is that this is a unique disease with a specific geographical distribution. So here you see that it affects some of the, very north parts of America. So it used to be known as the Eskimo disease. In fact, we do see people in the northern belt of Africa transitioning to the Middle East, getting nose cancer. I think this speaks to the human migration pattern. But speaking of Asia, while China is shown as a high-risk region, in fact, it's primarily the southern China belt down to Vietnam, Singapore, Malaysia, and Indonesia. That's where essentially the southern Chinese migration. Whereas you look at the northern part of China, NPC is actually a very low in incidence. Now, you hear this a lot, and the truth is this. I mean, Epstein-Barr virus is a virus that is, very endemic almost similar to COVID. All of us get it or exposed to it when we're young. But in essence, it's a combination of being infected with this virus when we're young, then plus the Southern Chinese genetics, then add them together, they're sort of predisposed, not all, but predisposed Southern Chinese, be it the Teochews, the Hokkiens and all that, to be susceptible to nose cancer. And in fact, the link between this EBV and nose cancer was established way back almost 50 years ago. If you look at this, where the first discovery was made by, Sir John Ohl, and when they found that there was actually EBV genome detected in NPC cells in 1973. So what are some of the stages and how do we stage? So naturally, stage 1 will be very isolated. Stage 2, you start seeing early spread to the lymph nodes because the nose is a very rich organ with lymph node channels. I always describe lymph nodes as train tracks. My patients, where you just imagine these are train tracks leading from the nose itself, but still they're not big. And then stage 3 is when it invades around the region. So the brain, the lymph nodes, it starts going to both sides. And then stage 4 is when it starts going more superiorly, that means above, to infect the brain. And then, or in fact, it hits the nerves, or it starts spreading downwards. And I'll show you more pictures later. And of course, now the thing is that we've got to make the distinction between stage 4A and stage 4B, because essentially stage 4A patients are still curable, while stage 4B patients is when NPC has already spread to the lungs, the liver, and the bone. And these are the 3 common sites where NPC or nose cancers like to travel to. Now, what is this humbling and staggering fact? Now, if you look at the breakdown of stages across all new NPC cases that are diagnosed in Singapore every year, and this is data from the Singapore Cancer Registry. If you look across from 2008 to 2017, over a 10-year period, the point I want to make here is that if you look at the breakdown of stage 3-4 patients, in fact, I always tell my patients, 50% of patients, when they first present with stage 4 disease. Now, this has not changed, despite perhaps one could argue the growth, the affluence, the improving affluence of our general public, the increasing awareness of health and everything. But despite that, patients do present with advanced disease, and it's often through no fault of the patient. In fact, because nose cancers tend to be very insidious, with minimal symptoms. And sometimes patients may present very early on, and when we do a scan, we realize that the tumor has been more extensive than we originally imagined. Now, the other staggering point to make is that NPC is a health problem that affects young males. Now, I'm not trying to be gender biased here, but the reality is if you look at the statistics between a very niche age group of 35 to 65, and this is data reflection of the Chinese male population, you see that in the early years, in fact, nasopharynx in this age group belongs to one of the top 3 cancers. And even though the incidence have gradually dropped over the years, it still remains at a very high incidence rate among this group of population. Now, why is it so important to highlight this fact? If you then think in terms of this disease as being something very curable, then we're speaking about a group of patients where they are at the peak of their socio-economic activity. And then fast forward, if you imagine that NPC patients tend to live to, on average, Singaporean males living to 83 years old based on our median life expectancy, then essentially if you have a patient diagnosed at 40 years old, then you're looking at a 40-year runway where in terms of not just cure, but quality of life issues play a big part in terms of deciding the intensity of treatment and the subsequent quality of life. So I think this is often what we think about when we see a new patient in our clinic. So to set a stage, I think just to recap, what is the, how do we stage nose cancer? So this is the nose, and as nicely shown by Dr. Lena Tan earlier, when you do a scope, this is what you essentially see, the full view of the nasopharynx. But often, if you look at just the proximity, how close the bone is to the nasopharynx, it doesn't take a lot for the tumor to just hit the bone. And when it does, naturally, this patient becomes a stage 3 nose cancer. Now, when we talk about neck disease, again, this is how we stage nodal metastasis or lymph nodes in the neck in NPC. When it just goes below just the Adam's apple, then this patient becomes a stage 4A NPC. So again, the point to make here is that it doesn't take a lot for a patient to essentially go from early stage disease to advanced stage disease. And this is how we stage, but the point just to make here is that the majority of patients, as I've shown in the earlier statistic table, present with stage 3-4 NPC. Now, what we do notice, and interestingly, is we see a nice dichotomy of how patients present to us in the clinic, which makes us think about the value of screening. Now, we see some patients where the disease, for some reason, is very, very limited. They may be picked up on screening, or they may have very mild symptoms like blocked nose or blocked ears. And then when they come and we scan them, we realize that lo and behold, the cancer is very limited just in the nose itself. Now, but interestingly, I do have a group of patients where they are, again, working individuals, with good jobs and are very conscious of their health. But when they present with headaches, loss of vision. And again, when we scan them, we realize that this patient already have stage 3-4 nose cancer. Now, sometimes we see patients whereby, although when we examine them, we see a very small tumor in the nose. But when we scan them, we realize that, in fact, the cancer started spreading down the lymph nodes. And in fact, it's sort of gone very extensively downwards. So again, it's kind of very unique and interesting why, despite this being a common disease, that we have patients with such distinct presentation. Some patients present only with very local symptoms, whereas some patients present with extensive neck disease. Now, of course, we have a subset of patients with very extensive disease, both with a lot of local symptoms as well as bulky neck nodes. So these are some examples. So this is a patient of mine again with very bulky nose cancer. So if you look from the front, from the scope, you will see that this is very small, but in fact, when you do a scan, you realize that the cancer sort of extends more, we call it posteriorly and to the right, where the patients manifest symptoms of chewing and a bit of headaches because it's invaded the muscles on the back. This is another example of a patient of mine where you can see that, again, if you just look at the face-on view of the MRI, then this patient actually have a very small tumor in the nose. But when we do an MRI, we realize that the tumor has in fact gone upwards, but not downwards, where it started hitting parts of the brain and so forth. And this patient then manifested with headaches, nerve problems, facial numbness, and so forth. But the point is that ultimately, with the treatments that we have these days, I'll show you later that the cure rates of these patients are actually very high. So what is the simplified version of how we think about, matching stage of disease to treatment, which is the main topic of my talk? I think suffice to say, for stage 1 nose cancer, we've seen the recent news of, MP B.M. King, where he had stage 1 NPC and he was successfully treated with radiotherapy alone. Now, when the cancer gets a bit more extensive, sometimes in stage 2 patients, about 40 to 50% may still be adequately treated with radiotherapy alone, but there are some patients whereby the cancer is a bit more bulky, where it's a much larger tumor in the nose, or it has gone to the lymph nodes, and the lymph node, even though it's just on one side or very limited part of the neck, it's very bulky, meaning it's more than 2-3 centimeters. We might combine chemotherapy with radiation. Now, it's really in the advanced stage 3-4 patients where treatment can be a bit more complicated. It often, to simplify to the audience, it will require a combination of radiation and chemotherapy. And just not to confuse you all, the chemotherapy and the radiation can be sequenced in many ways. Simply put, often in these patients, it's inevitable to receive radiotherapy with chemotherapy given together, meaning that when the patient undergoes radiotherapy, it's daily sessions over 6 weeks. So it comes out to about 30 or 35 sessions. And then on some of the days of the radiation, they'll receive chemotherapy. But additionally, for some patients where we think that the risk meaning the risk of spread to the lungs, liver, and bones is very high, then we might add more chemotherapy either before the radiation or after the radiation. And so this summarizes the treatment schema for stage 3-4 A NPC. Now, of course, if the cancer, we find that the cancer has already spread to the other sites, then systemic therapy, meaning that chemotherapy first, and or with or without immunotherapy would be the first line treatment, because that would be the first the key backbone where you're really trying to eradicate and shrink the cancer all around the body, including the nose, the neck, and elsewhere in the liver or wherever you're spread to. So I won't go into details here, but the point I want to show with this slide, so this is the updated algorithm or treatment pathway of how we would treat nose cancer. But it emphasizes, or it sort of illustrates to you all that there's a wide degree of heterogeneity in terms of the different pathways you can take. And the impression I want to make to the audience is that we don't just speak to stage alone. In fact, we are compelled by a lot of precise markers that we have, be it the PET scan, the liquid biopsy, that we can actually decide or break down patients by stage into even more specific treatment pathways to then decide how much to intensify and how much to de-intensify the treatment so that we can spare their side effects. And what about the cure rates, which would be the interest of everyone here? Now, of course, this is based on data of 1,000 patients that we looked at. They were treated in NCCS, and in terms of 5-year cure rates for stage 1-2 NPC, I'm pleased to say that we're looking at above 95% survival rate. Now, one important point to make here is that if you look at stage 3 nose cancers, we're still, despite this dismal sort of pictures I've shown the patients, in fact, more than 85% of patients remain cured. And if you look at stage 4 patients, still the odds of being cured is in the range of 60-70%. Now, the point I want to make here is that these cure rates are only achievable because we are able to match the right treatment to the right stage. So meaning that if you have used radiotherapy just to treat stage 3-4 nose cancer, then you're looking at a much lower chance of cure. So I think it's important to make that impression across to the patient that if you do come with aggressive disease, that it requires a combination of treatment, and just one modality alone is unlikely to achieve such optimistic results. Now, I'm also happy to say that despite even in patients with terminal nose cancer where it's spread to the lungs, liver, and bones, we're still looking at an average lifespan of 2 to 3 years because of the slew and the broad spectrum of drugs, and in combination with radiation and surgery that we can do for patients these days, that could actually achieve a lasting disease control. So in the next segment of my talk, just for a few minutes, I wanted to sort of bring you through what is the treatment pathway and the process. I can't go into too much details here because some of it may be too complicated, but I'm happy to do that during the Q&A. But it helps to dispel some of the concerns of patients, and I think also to showcase that how advanced the treatments have come along the way. Now, as part of radiotherapy, there's a few processes that patients have to go through. First, a mask has to be made, because why? We do the mask before a scan. Now, sometimes I get patients asking me, "Oh, Dr. Chua, I just had a scan done, before I came to see you. Why do I need to do a scan again?" Simply put, because radiation is very precise. We need your head to be in a similar position every day for treatment, and therefore this mask has to be made. And then once the mask is made, we'll then do a scan for you, whereby we'll use that scan with your neck and in that specific position, and then myself and my colleagues will actually outline and delineate the target where the tumor is and the area that we're going to deposit the radiation dose. And so this is essentially what we do. Now, when we do the planning, we include information from all the scans, not just the CT scan, but we repeat the MRI and the PET scan with the mask in place so that we can register all 3 images. Now, the point is that you want to leverage on the available and advanced imaging modalities that you have so that you get the best of all information. So when we do that, it's essentially an illustration of what I would outline. I will essentially draw the tumor based on what I see on the CT scan, the MRI, and the PET. And so then you get a very accurate delineation of the tumor. Now, beyond that, if you look at this, in this example here, if you look at the green line, this is where the nose cancer is for this patient. But we can't just treat that area itself. So when we talk about precision treatment, I think patients always get, a bit concerned and they're worried about side effects. And they will ask me, say, doc, why don't you just take it out? Or why don't you just treat that area? But because nose cancer can spread, you see, if you look at the brain itself or the nose region, you see all these little holes here. And these are holes, essentially, they are very soft bone where the nose cancer can infiltrate. And so when we treat, we have to treat a region around the nose itself. Now, but it's important to highlight that in this, what we call microscopic region, where this region are not perceived to be involved, we don't have to use a high radiation dose. So we use a much lower radiation dose to spare side effects, but this is a dose that is sufficient to neutralize any cancer cells in this region. So the thing is that this target delineation process, this radiotherapy treatment process, is a very detailed, almost akin to surgery, but it's done in front of a computer. We plan it, we draw the target, and then after that, together with our physicists, we outline where we want the radiation doses to go. So I'm glad to say that we've come a long way from the two-dimensional era. We used to give radiation, not in my time, but I was fortunate to see it just as I was doing my training, 15 years ago, where we were doing sort of x-rays and then using a crayon, drawing where the tumor is, and then drawing lines where we would actually block out the radiation field. So we will block out ulcers in the mouth, block out radiation to the brain, and then so forth. But the point is that when we did that, and patients always talk about, my uncle was treated 30, 40 years ago, and he had such severe side effects. And simply put, because we had limited ability to shape our radiation dose. Now, if I were to just bring you through this very quickly, this is a patient that was treated using the old technique, where you see there are two fields, one on the left, one on the right. And if you look at these other radiation lines, what you essentially see is everything gets treated with a single radiation dose. So there's no way, even though this is your target, to shape the radiation dose around this curvy target, and everything from the cheek, the bones, gets a uniform dose of radiation. Now, we have come a long way, this from 3D to being able to draw the target, now to being able to shape the radiation dose, and to quickly show you these days, how do we treat patients? Now, when we started IMRT about 6 or 8 years ago, which is intensity modulated radiotherapy, we have now evolved a technique now to what we call arc therapy, where we have in essence been able to treat the patients from 30 minutes using the old IMRT technique to now 7 minutes, where patients lie down, the mask is slapped on, and using just two cycles of radiation beams, it's going one circle and another circle after that, we're able to complete the treatment of the patient. And now, how are we able to achieve very steep dose gradient? So what I mean growth gradient, meaning dropping the radiation dose from the maximum to the lowest radiation dose. And because if you look at the beams here, every single degree, we are essentially modulating how much radiation beams go through. And just to show some example, if you look at the different percentages of dose, so the green line here demarcates the full dose, and then the orange line is 50% of the radiation dose. We're able to really push the radiation dose away from the oral cavity, which is the mouth, away from the spinal cord. And if you look at some of the other areas you can spare, for example, like the brain, we're really able to push the radiation dose downwards so that a big part of the brain is spared from high dose radiation, where it really causes a lot of damage. If you look at the salivary glands, where the saliva is produced from the side, we're able to really push. And in fact, here you can look at the 20% radiation dose is actually away from the salivary gland. So part of the salivary gland, in fact, gets spared from any radiation. And if you look at the throat, looking downwards, again, you see a sparing of this midline structure. So we can afford to do all that now, so that this actually helps to minimize the severity of the symptoms. Now, patients do get side effects, don't get me wrong, but it's just the severity is a lot more lessened, attenuated. So this is an example of a patient of mine, 50 years old, very active, stage 1 nose cancer. He underwent 30 sessions of radiotherapy. This is the tumor on the left side, seen on MRI. You see this on the PET scan. And this is the radiation regime that we designed for him. We gave the full radiation dose to the main tumor. we gave a lower radiation dose to the surrounding organs. And then to the rest of the nose, part of the neck, and in fact, the opposite side of the neck gets a lower radiation dose, and then a lesser area. And then the same side gets a much more extensive or comprehensive radiation, but to a 80% or a 30% reduction of the full radiation dose. You can see how tight the radiation delivery is, where we try to really treat the target that we want to irradiate. We don't treat the whole big area extensively, and then really make an effort to spare toxicities to the brain, the salivary glands, and the other parts of the organ. Now, what are some of the side effects? Briefly, I think they go in chronological order and over time. The first week, patients are very well. The second week, almost 90% of patients will tell me this thing, that, oh, Dr. Chua, I've lost my taste. I can't, everything seems very bland. My mouth is dry. And this is unfortunately the case, but it does recover about, 1 to 3 months after radiation is completed. Majority of patients do recover 90% of their taste buds. Now, over the course of treatment, the mouth does become more dry, but by about the halfway through treatment, they'll say that there's pain when swallowing, but the pain is not really pain, but it's manifested by the difficulty in actually swallowing a regular diet. So when they eat rice, chicken, they find that it's really hard to put the food through because the muscles are weakened. So that's why during treatment, we do link our patients up with speech therapists who tend to teach the patient exercises to try to sort of, retain and prevent further deterioration of this side effects. And then about week 5 or 7, often patients are still well. They don't really need feeding assessment. We encourage them to have milk feeds, porridge kind of diet, but they do lose a bit of their hair, not the top, but just around the sideburns, and then they get a bit of weight loss. But we do expect a recovery within a month after radiation. Now with chemotherapy, again, just to emphasize, it's not the classical chemotherapy where you see patients vomiting away and losing their hair. The chemotherapy that's being used for nose cancer is a bit more specific. Often the common symptoms are more related to constipation, a bit of nausea, and loss of appetite. So I think when you put them together, it can compound these side effects. And often that's why during the weekly reviews of the treatment, we do watch the patients closely to make sure that they are able to sort of get through. This is just examples. This is, again, very severe burns, but this is a 67-year-old patient who underwent chemotherapy and then chemo radiation. So it's a very long course of treatment. And I'm glad to say that she has recovered subsequently. And this is another patient undergoing chemo and radiation. This is her skin at the end of treatment. And often this is at the angle of the neck and the shoulder is where they get a bit more sort of burns. But you can see that about within 2 weeks, much of the skin has healed, and I just encourage them to put moisturizers after that. And this is her when she saw me a month later. But importantly, you see that in the patient I showed earlier, within a month, 2 months post-radiation, you can see that there's complete resolution of the tumor. I think this is what often patients look forward to, that with a very specific treatment, with minimal downtime, still being able to travel daily for treatment, that they actually do a full recovery. Now, finally, just to highlight that one of the points, a brief point to make, that these days, we're glad to say that we actually have a blood test that's able to allow us to do screening, track patients when they first see us, and then also assess whether the treatment is a success, and then even for follow-up, because we can't do scans of patients all the time, by a simple blood test, we can determine whether this patient is still in remission or there's early indication of the cancer coming back. And so finally, with the last part of my talk, I would like to just sort of do some advertisement here and I'm very glad to say that the Ministry of Health, together with the National Medical Research Council, has actually invested in a $10 million national program that's specific for nose cancer. And it will cover basic discovery, and it's a collaboration across several institutions on the island, and it will cover novel discoveries as to the genetics of nose cancers. Why do people in Singapore remain to get nose cancers? And in fact, Malay patients do get nose cancers as well. And it also covers screening, and then also looking at personalized treatment based on your patient's risk profile, and so that we can actually accelerate drug discoveries for patients who actually require new drugs to extend their survival. So with that, thank you for your time, and happy to take any questions later.
Thank you very much, Prof. Chua, for a really informational and instructive talk. It's fascinating. By looking at all the scans, we really see why NPC is considered a hidden disease. And also we have learned that indeed the treatment can be quite complex. So for the next portion of the webinar today, we have Dr. Kimberly Keong, who's a consultant in otolaryngology, who will be talking about otorhinolaryngology, who'll be talking about the surgical treatment for nose cancer. Dr. Keong, if you're ready, please go ahead.
Thanks, Simon. Okay. Okay. So mine will be the last talk for today. So thank you everyone for staying on till now. I hope this talk will be interesting for everyone. Okay, so just an overview of my talk. First, I'll go through the role of surgeons or surgery in NPC. In Dr. Melvin's great talk earlier on, we noted that the treatment of NPC for all stages seems to be radiation. So where do surgeons or surgery step in for NPC? The next point will be on recurrent NPC because this is primarily the role of where surgery is involved. And then I'll go through in a bit more detail about the surgery for recurrent nasopharyngeal carcinoma, and then lastly about other potential surgeries that we can offer to NPC patients. So in terms of the role of surgeons, those of you who are patients having NPC or know patients that have NPC, you will notice that the follow-up of these NPC post-treatment tends to be with the radiation doctors as well as surgeons, alternating between monthly in the first year and so on and so forth. So why do we do this follow-up? Firstly, we want to monitor for recurrence, which means that the cancer has come back. And also we want to monitor for side effects of treatment. Dr. Melvin went through some earlier, and later I'll cover a bit more side effects of treatment where surgery can be involved. Okay, so for surgery, we primarily I have divided them into NPC recurrence, as well as any hearing complications related to the disease or treatment. So this is somewhat similar to what Dr. Leonard showed earlier on. Otitis media with effusion basically means there's water behind the eardrum. Okay, so in the picture on the left, we can see that there is a clear, normal-looking eardrum. Okay, whereas the picture on the right shows a darkened appearance. Sometimes it may appear yellow as well, and that indicates water or fluid buildup behind the eardrum. And just to recap again, why this happens. So this is an illustration of the nasal cavity, the Eustachian tube, as well as the middle ear. So in nasopharyngeal carcinoma or in the treatment of NPC, the Eustachian tube function may not be normal. And normally this serves to aerate the middle ear, but in cases where it's not functioning as well anymore, negative pressure can build up in the middle ear and you get fluid behind the eardrum. And this causes symptoms such as hearing loss or the sensation of having a blocked ear. So what surgery can we do for this? This is termed a myringotomy, which means to make a cut in the eardrum, as well as a tube insertion. Okay, this serves to drain out the fluid as well as allow air to go into the middle ear to allow it to function normally. This procedure is done under local anesthesia. Okay, so you'll be awake during this procedure if you should need it. And over time, this tube, this little blue tube that you see in the picture, will migrate out and the hole should close up on its own. However, there are some potential complications that can occur. So some patients can have persistent ear discharge from this ear tube after it's placed. There is a potential for infection as well, which can cause more ear discharge as well as sort of a foul smell from the ear. There are instances of a retained tube. So like I mentioned earlier, the tube generally should come out over time by itself. But in some patients, this tube can remain in the eardrum. And lastly, in patients who have had NPC and radiation before, sometimes the eardrum does not close up after the tube drops out, and you can remain with a permanent hole in the eardrum. Okay, now the next topic I'll go into is recurrent NPC. As I mentioned earlier, the term recurrent means that after initial cancer treatment with radiation, the tumor has come back. Okay, so unfortunately, this happens in about 15 to 58% of NPC patients. And we divide this generally into local, versus regional versus distant recurrence, okay? And I'll explain what these terms mean. So local recurrence is, as the picture on the left shows, the tumor coming back where it originally came from, which means the nasopharynx at the back of the nose. Okay, what I mean by regional recurrence is that the cancer or the tumor comes back in the lymph nodes, in the neck, as seen on the picture on the right. And distant recurrence, which I'm not really talking about here, means spread to other parts of the body, such as the bone and the liver. And in my talk, I'll focus on local as well as regional recurrence, because those are the ones that we can do surgery for. So when patients come back with a recurrent tumor, okay, majority of them are actually just the nose alone. Okay, about 25% develop recurrent disease in the neck, lymph nodes, and about 8 to 28% develop tumor in both the nose as well as the lymph nodes in the neck. So generally, we would say that the interval between the initial treatment and the disease coming back ranges from between 1 month to 10 years. However, majority of them actually develop this recurrent disease within 3 years of treatment, which is why we emphasize the need for close follow-up, especially in the first couple of years after treatment. Generally, the first 1 to 3 years are the most critical, which is why the follow-up duration is much shorter in this period. So this is what a local recurrence may look like, somewhat similar to when small nose cancer initially pops up, just a small growth seen at the back of the nose. So the most common symptoms are bloody nasal discharge as well as headache, which can occur in about 30 to 40% of patients. So bloody nasal discharge is one of the symptoms that we look out for even at the initial presentation of NPC, whereas headache is something that is more common in a recurrent disease. Some patients may not have any symptoms at all, and actually the recurrent disease is picked up at routine follow-up or through scans or blood tests performed by your doctors. So at each follow-up after treatment of NPC, we will perform a nasal endoscopy. Just now, Dr. Leonard showed what the process is like. And each time we would look at the nasopharynx carefully to assess whether there's any tumor growth there again. Periodically, we would also order some scans, for example, a CT or MRI scan or a PET scan in some cases to see whether there's any disease anywhere in the body. And lastly, as Dr. Melvin mentioned, there is a blood test, what we call Ebv Dna, that we do periodically for patients post-NPC treatment, because if at any time we see a jump in the numbers, we may suspect that the disease has come back again, and then we try and hunt for where it may be. Okay, so when we suspect or detect the local recurrence, the first thing that we need to do is a biopsy. Okay, so that's pretty much similar to when we first detect the initial disease. We need to sample the tissue to make sure and confirm that it truly is the disease come back. Then we need to do further scanning to check whether it's spread anywhere else, for example, to the lymph nodes or the rest of the body. And thereafter, we want to consider the treatment options. So these are the 3 treatment options that we may offer in a recurrent disease. So surgery, repeat radiation, what we call re-irradiation, or palliative treatment. So why I say surgery if possible is because although radiation treatment is the best form of treatment upfront for the initial disease, as Dr. Melvin was explaining earlier on, to give a second round of radiation to the nasopharynx actually comes with a higher risk, which is why we prefer not to give it a second time if possible. And we would choose to do surgery if it doesn't cause too many complications. And then lastly, we reserve palliative treatment for cases where the tumor is too large or has already spread to other parts of the body. That meaning things like chemotherapy to control the disease, but not so much aim for cure of the disease anymore. So this is an MRI scan. You saw a couple from Dr. Melvin earlier on, but this MRI scan basically illustrates once again a nose cancer at the back of the nose where the white arrow is pointing. And we can also see that I've drawn out 2 red dots here. And this is what I'm going to explain later on that is relevant. These 2 structures are actually major blood vessels that supply blood supply to the brain. And if these blood vessels are damaged during surgery, they can lead to stroke or massive bleeding that can even lead to death. So this is more relevant when I go through more details about surgery later on, but just keep this in mind. Okay, so in terms of surgery for local recurrence, which once again is tumor coming back at the back of the nose, we can divide surgery into open surgery, which means surgery that involves making cuts on the face versus endoscopic, or what we call keyhole surgery. Okay, so you can see the picture on the left is an image of a patient that has gone through open surgery. So you can see a pretty long incision line following the side of the nose and going down to the lip. So although this heals reasonably well in most patients, it is still a cut on the face and requires time to heal. Whereas on the right, we can see a patient with no cuts on the face. You can possibly see a few bloodstains around the nose, but that can be easily cleaned up. And that's one of the benefits of endoscopic surgery. So in terms of open surgery, okay, I didn't want to include two graphic images here, so I just have an illustration of what that surgery entails. So the nasopharynx, as shown in the anatomical images by Leonard earlier on, is a very deep space within the head, which is why to access it for surgery is quite technically challenging. So this approach is what we call a maxillary swing approach. And what that entails is that the maxilla is basically the bone of the cheek. And what we do is swing it open like a door to access the tumor right at the back of the nose. And thereafter, we manage to swing this tissue and bone back to its original space after the tumor has been resected, and then complete the closure. Okay, so the upsides and downsides to this open approach. So the good point is that with open surgery, we are better able to control that major blood vessel that I was telling you guys about earlier. And also with open surgery, we're able to place tissue in from other parts of the body, for example, the leg or the arm, to resurface this hole that we've created at the back of the nose. We primarily want to make sure that this major blood vessel is not exposed to air or the secretions from the nose and the mouth, so that we don't have bleeding from this blood vessel. However, the downsides to this is that, as I mentioned earlier on, there will be a facial incision or the scar. Okay, there can potentially be an eyelid deformity as well, as seen in the top picture here. The lower eyelid can actually be everted or flipped downwards. Okay, and one of the other complications is that there can be a persistent connection between the nose and the mouth, as shown in the picture lower down. Okay, as in certain cases, the healing doesn't heal fully, and then this connection is created. And lastly, some patients can also have impaired jaw opening after this open surgery. Okay, and then next we go on to endoscopic surgery for recurrence at the back of the nose. This is a form of keyhole surgery because in a way it's performed through the nostrils without any external cuts on the face. This is generally reserved for smaller tumors because the limitations of endoscopic surgery is that we are not able to control the blood vessels as well. Okay, so just some pictures to show you what it looks like during endoscopic surgery. So this patient of mine had a small recurrence at the back of the nose, just a little lump you see there. Okay. And then this is after removing it. Okay, so we can see a lot of exposed bone, exposed tissue, as well as exposed muscle in that area. And then thereafter, we can put some local tissues from the rest of the nose just to cover up that area to allow it to heal better. And the pros and cons of endoscopic surgery. So as mentioned, there's no external incision or scar. Okay, using the endoscope also gives a better visualization as well as a magnified view. So the pictures I showed you earlier on makes it seem like that area is quite a large area. But in actual fact, the nasopharynx is probably only about 3 cm across. Okay, so you can see that the endoscope provides a very good view of that area. Also, studies have shown that in well-selected cases where the tumors are relatively small, this approach to surgery has actually a very good outcome. Okay, the downside to this endoscopic surgery is that it's not possible for larger tumors because of the difficulty in controlling bleeding from major blood vessels if it happens. And also, it's generally more difficult to place tissue from elsewhere to cover either a large defect or hole up, or cover the major blood vessel if it's exposed extensively. Okay, so some potential effects after a nasopharyngectomy has been performed, which is surgery for removing a local recurrence. Some patients complain of headache or neck pain after the surgery, but it tends to improve over a couple of weeks. Some patients may complain of ear blockage because the Eustachian tube, as I mentioned earlier, is in close proximity, and some parts of it may have to be removed during surgery. Some patients can have bleeding. Usually it's just small amounts and not troublesome, but rarely can there be major bleeding after the surgery. Some patients can have crusting as well, which means that there are large sort of healing tissues at the back of the nose. We would encourage our patients to use nose wash to keep the area clean. And lastly, as with any other surgery, there is a possibility of tumor coming back thereafter. Okay, the next topic I will go into is regional recurrence, which once again I will explain as a tumor that has spread to the lymph nodes in the neck. So the surgery that we perform for this we term as a neck dissection. And what that means is to remove the lymph nodes while preserving important structures in the neck. So in general, the neck has more than 150 lymph nodes. So a lot of patients ask, is there any problem after removing the lymph nodes in the neck? And the answer is generally no. There are other lymph nodes, for example, at the other sides of the neck or in other areas that can serve their function. Although removing some lymph nodes in the neck can sometimes cause lymphedema, or to explain this is swelling in the face or neck region. So the neck dissection unfortunately requires a bit of a longish scar. So it's illustrated in the image over here, extending from just below the ear to the front of the neck, because we need to expose a large area so as to preserve the important structures in the neck. After neck dissection, patients will have what we call drains or tubes to drain the bloody fluid from the neck to prevent this from accumulating in the neck and causing things like infection. Okay, these tubes generally stay in on an average of 7 days, but it depends by case-to-case scenario. Okay, just a disclaimer here, the next slide that I'm going to show is a little bit graphic. So those of you that are squeamish or a bit afraid about blood, maybe I can just get you to look away for the next slide, and I'll let you know when it's over. Okay, so the next slide shows the image of what we see during a neck dissection. This is an open neck. And the reason why I'm showing this is to show that there are many major blood vessels and nerves in the neck. So the finger in the picture is actually holding away the major vein in the neck. Okay, and in the picture on the right is exposing the major blood vessel that I pointed out earlier in the image, that if damaged can cause things like stroke or catastrophic bleeding. While there are risks to these structures during a neck dissection, I want to reassure you that a neck dissection is a fairly common procedure in experienced hands and should not be too risky a procedure. That being said, in NPC, sometimes the cancerous lymph node may sometimes eat into the surrounding structures as it grows, and some of the important blood vessels and nerves may have to be sacrificed for cancer clearance. This depends on the individual patient as well as tumor, so really needs your surgeon to advise on what removal is necessary in that case. Okay, so now we're away from the graphic picture. Those of you can look back again. Potential side effects after a neck dissection include scarring or stiffness. Okay, so surgery alone by itself can cause scarring and stiffness in the neck. But patients with radiation before tend to have worse of these symptoms because of the two sort of combined effects of radiation as well as surgery. In cases whereby the tumor has affected the nerve that controls raising of the arm, some patients may have weakness in raising the arm. So this is illustrated in the picture that you see. So the gentleman can raise his left arm perfectly fine, but the right arm can only be raised up to that certain degree. And you can see the bone sort of is trying to compensate for that, but it's not able to raise the arm fully. Some patients may have an asymmetrical smile after the surgery, although this is usually temporary. And as I mentioned earlier, removal of the lymph nodes in the neck combined with the radiation therapy previously can lead to a facial swelling that may take time to go down, or may take further treatment such as physiotherapy or special massages to improve. And lastly, those patients that have radiation before can sometimes have a bit of a poorer healing than in patients who have not had radiation. And this can lead to wound complications such as infection or just taking a longer time to heal. And the very last part that I'll go into is just some other surgeries that can be done for NPC patients, either because they're newer treatments or they're done less commonly. So this part about robotic assisted nasopharyngectomy. So I think a lot of people are very excited when we talk about the use of robot or lasers for surgery. So some people have explored the use of robot to assist in the removal of a local recurrence combined with endoscopic surgery approaches. Okay, and we can see in this picture what the robot looks like. So in traditional surgery, the surgeon would stand in front of the patient and use instruments to perform the surgery. But in robotic surgery, as we can see on the right, the surgeon actually sits at what we call a console or a separate a table away from the patient and controls the robot that is just above the patient to perform the robotic surgery. So in terms of nasopharyngeal carcinoma treatment, the use of the robot is relatively new use of technology and it's not mainstream. The robot is more commonly used in other surgeries and is more mainstream in those for oropharyngeal and throat cancer, but not so much of NPC, but maybe we'll see this develop in time to come. Also, the use of the robot in NPC may not be suitable in all cases. The next thing that surgery can be used for is osteoradial necrosis. So it's a very, very long term, but basically it means that the tissues at the back of the nose have been sort of devitalized or unhealthy or infected after radiation treatment. And this sort of unhealthy tissue that you can see in the picture can lead to a foul smell in the nose, can cause bleeding as well as pain. And sometimes the bleeding can be catastrophic because, like I mentioned earlier, with the major blood vessel being in close proximity at the back of the nose, the unhealthy tissue or infection can actually affect this blood vessel and cause major bleeding. In general, treatment is antibiotics as well as regular cleaning, but sometimes surgery can be involved to remove some of the unhealthy tissue and trying to place fresh tissue in to allow for proper healing. And the last two slides that I'll be showing you is a bit more relevant to hearing in NPC patients. So not necessarily for patients with recurrent disease, but any NPC patient that has had treatment and has problems with hearing can potentially benefit from these surgeries. So this video that I'm going to show you is called Eustachian tube balloon dilatation, which is the use of a balloon to try and expand the Eustachian tube for patients with problems of persistent fluid in the middle ear. So this is considered a minimally invasive option to try and open the Eustachian tube. So here's the video. You can see the instrument going to the opening of the Eustachian tube. We're deploying the balloon and expanding it at the moment. And then we leave it there for a while. And then when we remove the balloon, we can then see that the Eustachian tube opening is wider. Okay, so some patients do derive benefit from this, but because it is not, doesn't involve any cuts or what, this problem unfortunately may recur and may require repeated procedures. Okay, and the second part for hearing is that radiation can sometimes lead to profound hearing loss. And cochlear implant is basically an implant in the inner ear to try and restore hearing. Okay, so in the picture above, we can see that the implant has actually been placed inside the inner ear, and a small well has been drilled in the bone to place the external part of the implant. Thereafter, it's closed up, and after appropriate time amount of healing, the implant can be turned on and used. Okay, so in the lower picture, we can see what the implant is like. It looks a little bit like a hearing aid for those of you who have had hearing aids, but basically it connects via magnet to the skin. And you can see that in this patient, she has long hair. The hair covers it pretty nicely and you can't see it very well thereafter. Okay, so this is an option for people with profound hearing loss, although in post-NPC radiation treatment, this surgery may be a little bit more complex. Okay, I've come to the end of my talk now. Thank you everyone for staying on. And I think we'll move on to the question and answer now.
Thank you, Dr. Keong, for your very good talk as well. And it's very interesting for people to be able to see some of the photos and diagrams that you've shown, since they don't have a chance like the rest of us to take a look behind the skin. Some of the participants have mentioned that. It also shows that the treatment of NPC is a multidisciplinary effort between surgeons, ENT surgeons, head and neck surgeons, as well as radiation oncologists and other specialists as well, whom we have today in our panel. So the next segment will be for our experts to answer some of the questions from the audience that have been posted earlier. So we will proceed with the Q&A session now. We can have the organizers flash up the questions, please. We will address them one by one. So the first question has to do with the symptoms of nose cancer, and we've received many of those. So maybe we can talk about some of the symptoms again, and specifically, is blocked nose a symptom of nose cancer? Dr. Lena, would you like to take that question?
Yep. Yeah. So I think, like I mentioned previously, blocked nose can be a symptom of nose cancer. However, I think we need to see in context. So number one is, if the blocked nose is persistently there and is there all the time, and he's been there for a duration of more than 2 weeks, and if there's any other associated symptoms such as bleeding in your nose, or you have any blood tinged saliva or sputum, then I think it is necessary, or it may be advisable for you to seek help or see a doctor to just make sure that we are not dealing with nasopharyngeal carcinoma. Otherwise, definitely blocked nose, if it occurs intermittently, can be, let's say, if it changes with the day or the timing of the day or the temperature, then it could also be a symptom of, a sensitive nose, what we call allergic rhinitis, or in layman's term, it can be known as sinus problems. Yeah.
Thank you. Next question, please. So for those who have a sensitive nose, sometimes they are prescribed nasal steroid sprays. So can these lead to any complications such as nose cancer?
Yep. So I think this is a very common question. It comes out in the clinic as well. I think currently there's no conclusive evidence to show that the use of nasal steroid sprays can, or will lead to a cancer or any nasopharyngeal problems. Definitely, there can be other side effects. Some of the common side effects that we do see with patients who use nasal steroidal sprays will be, some occasional light bleeding in the nose. This could be due to either the steroid sprays, drying up the nose a little bit more, or maybe thinning the lining of the nose a little bit more. Or it can also be due to a traumatic use of the nasal sprays, because it requires patients to insert part of the nasal spray equipment into the nose. Yeah. And I think there are also some other questions that occurred in the Q&A chat box to ask whether if patients with allergic rhinitis or sensitive nose is a direct cause of nasopharyngeal carcinoma, and currently there's no conclusive proof to it. Yeah.
Thank you. Next slide, please. Yeah. So it has been mentioned during the initial talk that many of the nose cancer patients are detected at advanced stages because the early stages are asymptomatic. So what can one do to prevent and also to detect it at an earlier stage? Dr. Leonard, maybe you can try that again.
Sure. So definitely, I think there are, number one, no ways to really prevent nasopharyngeal carcinoma. Of course, I think what's important is definitely monitoring the symptoms of what I've mentioned previously. Secondly, of course, it is to also, make sure that individual continues to, monitor or to keep to good health, habits such as, avoid smoking, avoid alcohol, and avoid maybe chemical fumes, which are actually not really proven to be a direct causative factor for nasopharyngeal carcinoma. However, I think if patients do have any worries, like let's say if you have nose bleeding and you're concerned and it's occurring very frequently, or let's say you have a family history of 2 or more first-degree relatives, which is defined as like your parents or siblings, then it may be good to actually make an appointment with a head and neck surgeon or ENT surgeon to just have a look at the back of the nose and make sure that we're not dealing with nasopharyngeal cancer. Yeah.
Thank you. So I think the next question is quite similar. With family members who have NPC, how can we prevent or reduce the chance of getting NPC? And I think you already answered this question just now. So any warning signs, any red flags that have been mentioned, do seek early attention of an ENT or head and neck surgeon. Unless our panelists have anything else to add, maybe we have the next question.
No, nothing there.
So the second question is quite specific. I think Prof. Chua has mentioned this already, but one more time, what is the estimated survival rate for patients with stage 3 NPC or anything else on the topic they wish to add?
Thanks, Simon. I mean, I would typically quote between anything more than 80% for stage 3 nose cancers. That's the rates that we see, based on contemporary treatment from clinical trials and also from our own database. Yeah. Are there some questions on screening? Because I just want to make a quick point earlier about what Leonard was sort of sharing, because I think the first few questions were about early detection, and the because screening in those so screening is a very complex topic, and I thought I just want to clarify some of the concepts to the audience. Now, of course, we've seen the data. 70% of patients with nose cancers, newly diagnosed, present with stage 3-4 NPC. Now, in terms of screening, there are two components when we think about screening. Of course, there's screening of an individual. That means as an individual patient, you're concerned, you walk into a polyclinic, and then, or your family physician, and you request for a slew of screening tests. So then one has to ask the question, what tests and how? And because as with every test, there's a chance that there could be a false positive test. So meaning that you do a blood test and there are a few of them out there, and sometimes the accuracy of this test may be suspicious. Now then, of course, the next question is also relates to the family risk factors. If I have a family member with nose cancers, then should I be concerned? Now, so I'll answer the second part, where in fact, in Singapore, there was a study done, it was published, where it was done by a few investigators on the island, and they looked at about 400 family members who were immediate family members of NPC patients. And they looked at a series of different tests. So I think the important distinction to make here is that there are different EBV tests out there. There's EBV serology, and even for EBV serology, there's a lot of different types, where there's VCA, there's EA, and then there's also Ebv Dna. I see some questions being put there. Now, the important thing to say is that the serology tests have different serology tests have different performance. So for VCA, which is one of the common tests being done, in fact, if you look at that study and several other studies, when you look at, if you just in terms of percentage of patients who are likely to be positive, in fact, 60-70% of the population, if you screen them, that means you take 20 to 60-year-old Chinese males, you do this test, 60-70% of them will actually have a positive VCA test. But among this proportion, only a small segment, less than 10 or even 5%, will actually eventually have NPC. So it's a very high false positive rate. So I think it's very important to make a distinction, because if you do that test, say for screening with your GP, then you get triggered to be seen by ENT surgeon. So then what happens after that? What's the cascade? Do you go for scopes every year and all that? Now, we found that, in fact, in that family screening study, another serology test, which is the early antigen, the EA test, seems to be a better marker. So a lower false positive background rate in the population, and a closer, or it sort of corresponds more closely to whether the patient is at risk of nose cancer. It doesn't mean that the patient has nose cancer, but is at risk of nose cancer. Now, the third test that we would like to talk about is actually the Ebv Dna test. And in fact, that test is even more challenging to interpret, because number one, the test, the readout of the test is very susceptible to which laboratory does it, to when the blood has been collected. And it's important that there are very strict protocols, be it whichever lab is sent to, that the test is done robustly, because the test can actually have very big variance even for the same patient. So when we did that family screening study, we realized that that test did not perform so well. So at SGH, at NCCS, a few years ago, we embarked on this international effort to actually harmonize our tests with laboratories in Hong Kong, Taiwan, US, so that at least now we can confidently say that a test done in SGH is not so different from the test done in Taiwan, in Hong Kong, and so forth. So I think that standardization of tests allow us to more accurately deploy this test. Now, but for screening, it works a bit differently. The serology test kind of speaks to the risk of a patient getting NPC, whereas Ebv Dna actually measures the possible presence of NPC itself. So the only best evaluation of this test was done in Hong Kong, where they looked at 20,000 patients. And among the 20,000 patients, they found that about 300 patients had a positive Ebv Dna test. And then when they repeated the test a month later, so they didn't put these patients directly through to have a scope right away. A month later, they repeated. About 100 plus continue to have that test being positive, which means that about 200 patients actually had a false positive test. And among the 100 plus patients, only about 11 or so, even 11% or so, eventually developed nose cancer. So it's still a very small segment of the population. So I think when we think in terms of deploying this test, there's still a lot of unanswered questions here about what's the best test and so forth. So I think by sharing this level of detail to the audience, I want you all to be able to make the distinction when you go to your GP and ask for any screening test to understand the nuances behind this test. Now, lastly, I would like to say that we are about to commence on this national screening study to at least generate our own local Singapore data at scale. So 20,000 patients across all the polyclinics will be recruited, and then we will subject them to the test that I just described earlier, so that we can actually accurately report on the performance of this test, not just from people, but in our local data. I think it's important to understand that.
Thank you very much for elaborating on this. So if I may paraphrase, and can I ask you an additional question as a follow-up? So is it true to say that any screening test does not give definitive answers, but only speaks to probabilities of the patient either having an increased risk for developing nasopharyngeal cancer or of actually having nasopharyngeal cancer at the time? And therefore, the result of that test needs to be interpreted for each particular patient by a specialist, taking into account risk factors and so forth. Is that correct? Absolutely.
So just to go a bit further, for the serology test, that would be true. So serology test being the antibody test, the EA test that I spoke about, that would indicate that you might have a potential risk of nose cancer. But for Ebv DNA specifically, as Dr. Kimberly also showed, this test actually is a sensitive liquid biopsy that will indicate the early occurrence of nose cancer. So it is interpreted differently from the serology test. So if your Ebv DNA is positive, then often I would recommend the patient repeat another one. And then if there's two subsequent readings are positive, then this patient should be further investigated.
Thank you. Can we see the next slide? Because I think this one already has been covered. Okay, so this one talks about metastasis, which is the spread of the nose cancer from the original site to other organs. So the question here is about what are the other common sites of metastasis? Maybe Dr. Kim, would you like to answer this question?
So I think the common sites of metastases that Dr. Melvin mentioned earlier on would be the bone, as well as the lung, as well as the liver. Okay, so these are maybe picked up, for example, when we do PET scans, when we initially detect disease, and then we look at the PET scan for the whole body and we detect metastases in these areas.
Thank you. Next question. So along the same lines, I guess the answer is yes, that NPC can spread to other organs, but is NPC considered a primary cancer?
Yes, so NPC is primary cancer. So what we mean by primary is where the cancer first develops. So when the cancer develops in the nasopharynx, it is called nasopharyngeal cancer or NPC. So when it spreads to other organs, like the organ I mentioned earlier, that is called metastasis. I also mentioned earlier that the cancer can also spread to the lymph nodes in the neck. Okay, so that's the other region that it can spread. But the primary region would be the nasopharynx.
Okay, so some patient, one of the members of the public was asking today about pre-cancer diagnosis for nose cancer. similar to what we have, for example, in stomach cancer, which is called intestinal metaplasia. Is there such a thing as pre-cancer in nasopharyngeal carcinoma? And again, what will be the treatment of the pre-cancer state to prevent it from developing into cancer? Prof. Chua, maybe I'll ask you this question.
Thanks, Simon. So not really. I think one of the issues with, scientists have actually tried to study the sort of onset or the life cycle of NPC. And I think, even though, and I don't want to sort of confuse the audience here, but the point is that even though the infection tends to occur quite early on in life, so naturally one would think that if it occurs so early on in life, then if you screen the patients, maybe you may see an early precursor lesion, but it doesn't seem to be the case. For some reason, when the virus sort of reactivates again, and then results in having nose cancer, the next thing we see often, it jumps from, a benign looking sort of nasopharynx or the nose to just frank cancer right away. So there don't seem to be an intermediate stage for NPC specifically. I presume the audience was asking in terms of insurance. So I think to that point, I think, no, if you have NPC, it is considered cancer.
Thank you. So the next question is about treatment. And is there any role for what we call targeted treatment? I imagine in contrast to cytotoxic chemotherapy, is there any targeted treatment for nasopharyngeal carcinoma specifically?
Thanks, Simon. I'll take that one. I mean, the short answer will be no. So nothing that's approved at this point in time. There have been studies that were done, on some of the targeted treatment, like cetuximab or nemotuzumab, which is another version of, cetuximab or Erbitux. But the results are that it's not being superior to conventional chemotherapy, and therefore chemotherapy, even in the most frail patients, remain as the standard of care for nose cancer.
Thank you. So if a patient has undergone treatment for NPC, what is the probability that NPC will recur, meaning that it will come back? And once it recurs, is the treatment the same as the initial treatment, or is there a different approach then? And finally, in the event of recurrence, how does this affect survival rate for those patients?
Yeah, maybe I can take this one. Yeah, so the probability that NPC recurs after treatment is probably between 5 to 58%. And the treatment differs in that initial treatment of NPC is largely centered around radiation treatment, whereas the treatment for a recurrence really depends on where exactly the recurrence occurs and also how extensive it is. So if it is a local recurrence, that means a recurrence once again in the nasopharynx and is relatively small, it can be treated through surgery. If the recurrence is not amenable to surgery, for example, if it's too large or too close to the important blood vessels, repeat radiation may be considered again, with the caveat that repeat radiation sometimes can cause more extensive side effects. And if the recurrence occurs elsewhere, for example, the neck, surgery can be performed. And if recurrence occurs distantly, that means to other sites in the body, sometimes if it's small and single, surgery can be considered. But if it's quite extensive, spread to other parts of the body, then the treatment would likely be chemotherapy. The survival rate for recurrence really depends once again on the size as well as where it has recurred. But definitely the survival rate does go down once the NPC has recurred.
Okay, thank you. So we have covered most of the questions that have been asked, and we are coming to the end of our allocated time slot. So I would open the floor for our panelists to make any final comments, if there are any. And perhaps there was one more question I picked up from the Q&A just now, which is, is this EBV screening or is this EBV testing an uncomfortable procedure? You know, so some people may be unclear as to how the EBV test is actually done. So maybe we can have Dr. Lena explain about how is EBV tested and whether it's uncomfortable for the patient or not.
So the EBV DNA is actually a blood test, and it's actually so the blood will be taken from the patient, and usually the nurses will usually fill up about 3 small little blood tubes, and yeah, that's about it. It's not exactly a very uncomfortable procedure, except the fact that you will need to go through a prick by a needle. Yeah.
Thank you. Does anybody else have any last final comments?
No, nothing from me. I mean, thank you. I think we hoped we have given a good overview, and some facts and basically facts that have actually helped to dispel and reassure patients. But please feel free to verify. I mean, speak to your health professionals and to take this information. If you want to take this information forward, just make sure to speak to a medical professional as opposed to Dr. Google.
Yeah, I think that's good advice for the end. And thank you, everybody, for taking the Saturday morning to spend with us. And hopefully you will learn everything. We're very privileged to have all our specialists today to share their expertise on nasopharyngeal carcinoma. And please stay tuned for further events in the series, which will be, I think, showcased by the subsequent slides. And thank you very much. Have a nice rest of the day.